find information on the utility of genetic testing for unilateral. Our disclosure is that the clinical data is collected by Impact Genetics, and I'm the unpaid medical advisor, or was, now resign from Impact Genetics. So what we did was analyze 3,350 RB probands for constitutional RB1 mutations, and of course 60% are unilateral and 40% are bilateral, each one, and I emphasize the AJCC classification. It's very easy to call them carrying a germline RB1 mutation by each one. Of the bilateral, they all have an RB1 mutation, and that establishes the sensitivity of the clinical lab test to find a mutation that should be present in all bilateral. So we now can find 96%. That's an important number. For the unilaterals, if we look at the 19% will carry a constitutional RB1 mutation or pathogenic variant. And of those, 7 out of 11 would be constitutionals. In other words, you would find it in their constitutional cells. But for 4, they could be mosaic and you would not know it was present. So mosaicism is meaning the RB1 mutational event occurred during embryogenesis, and so only part of the cells of the resulting person, the mosaic person, will carry the RB1 mutation. You don't know what the percentage is, you don't know which cells of that adult or child will be affected and be essentially carrying an RB1 mutation. But they carry a risk for future offspring that might arise from that mutant cell. So when the parent is mosaic, it's very interesting. There's no risk for preceding family members. You can't inherit mosaicism. And that eliminates all those from routine screening, which is very cost effective. But of course, the offspring can be tested at any stage of embryogenesis or pregnancy and know which ones carry the variant, and those ones can be managed with early delivery or very early screening for RB1 tumors. And the consensus report, and this is another guideline in retinoblastoma. There aren't very many guidelines published, but this is essentially one for the genetics screening for children at risk. And this is led by Alison Scallett, and many other people participated as many good guideline development. So in conclusion, genetic testing for unilateral is important because 19% will carry a pathogenic variant that will be highly relevant to their offspring and other relatives. Some who won't need testing because you know what it is, and some will be defined in order to be able to optimize their opportunity for a good patient. And I think it's very interesting, the paper I just found this morning in 2023 on feeding back genetic information in Botswana. So that's a very interesting paper and relevant to Africa and the rest of the world. Thank you.
Thank you, Brenda. Any questions or comments? Brenda, maybe I can ask. Mosaicism I find difficult to deal with when you're screening the offspring of people who may be mosaic. Do you stratify those mosaic patients into a kind of higher risk mosaic and low risk mosaic? Or everybody's dealt with?
Well, everyone that you know is mosaic is at risk. And ones that could still be mosaic are less than 1% by the way it's screened for at Impact Genetics. So less than 1% is the figure.
Thank you very much.
Is Dr. Abhilasha Maheshwari from India talking about the AJCC-OOTF Task Force Retinoblastoma Registry. Lessons learned.
Good afternoon, everyone. I'm Abhilasha Maheshwari. I've had the privilege of working with Dr. Paul Finger, and this is the AJCC Retinoblastoma Registry, the lessons learned in advanced retinoblastoma. Specifically, how this international collaboration was used to discover vital practical information for a very rare tumor. The authors and gender supporting foundations had no conflicts of interest. Retinoblastoma data was collected from 13 countries over 6 continents between 2001 to 2013. All the authors were a part of the Ophthalmic Oncology Task Force. Thus, the AJCC Ophthalmic Oncology Task Force formed an international registry, and specialists from all over the world contributed in the creation of the 8th edition of AJCC Retinoblastoma staging system. Retinoblastoma is the most common eye cancer in children. This is why classification systems were designed to plan treatment, observe response to treatment, compare results, and quantify clinical research. The 8th edition AJCC Retinoblastoma was adopted by the Union for International Cancer Control, UICC, making it the most common world RB cancer terminology. It uses the TNM nomenclature for all the cancers in the body. The heritable trait H biomarker is used for the first time as retinoblastoma is a heritable cancer. Additional clinical features associated with the risk of metastatic spread include neovascular glaucoma, diffuse infiltrative retinoblastoma, anterior chamber tumor seeding, and intraocular hemorrhage. Retinoblastoma can also penetrate the orbit, termed as orbital retinoblastoma. These cases have the highest risk for metastasis and death. Such presentations are exceedingly rare in the United States, but not uncommon in countries like India and Africa specifically. Our next work focused on the retinoblastoma seeds. These tumor clumps are very difficult to treat. In these images, you can see a cloud-like tumor mass separate from the tumor arising from the retina. In the image below, there are tiny spheres of tumor cells which arose from the main tumor and are spread diffusely around the vitreous. We found that retinoblastoma seeds are very resistant to local treatment outcomes. Diffuse vitreous and subretinal seeds had a worse outcome than focal seeds, and these findings can be used to determine which eyes with RB can be salvaged and which cannot. Our most recent studies focus on the most controversial aspect of retinoblastoma care, which is when to enucleate or attempt saving the eye in advanced RB. At first, we focused on basically which are the features which predispose to metastasis, and then we approached the risk for metastasis based on pathology findings amongst enucleated eyes. These two complementary studies helped us understand which retinoblastoma eyes should be enucleated versus those where salvage attempt is safe. The AJCC RB staging is the first staging system where the clinical features are the risk for high-risk clinical features is seen on the left of the slide, and there is a disparity in tumor size criteria for advanced RB. Therefore, the AJCC-OOTF created specific size groups and explored which criteria was the most effective. Our results showed that AJCC predicted the risk of metastasis in advanced RB. Eyes with glaucoma, intraocular hemorrhage, and aseptic cellulitis had the highest risk, and they should be treated with eye removal. A salvage attempt in these cases jeopardizes the survival of the child. We also found that primary enucleation had a survival advantage in advanced RB. An attempt to save the eye increases the risk of metastasis by 3 to 5-fold. This critical information will be used by eye cancer specialists faced with making this difficult decision. A sensitivity analysis showed that more than 2/3 of the globe volume is the best cutoff for the risk of metastatic death in advanced RB. In addition, the variant of diffuse infiltrative RB had a significantly worse outcome. In cases undergoing primary enucleation, the pathological analysis to identify which eyes have the risk factors which could predict systemic spread of RB. These findings complemented our earlier results, and the presence of glaucoma, hemorrhage, and cellulitis were deemed as having the highest risk factor. The 8th edition AJCC RB staging was a multi-center international cooperative effort. It contained the data from 2190 RB patients from all across the world. A uniform use of staging system can positively impact data, reporting, clinical research, and patient care to answer critical questions that will help eye cancer specialists save both sight and life. These are the links for our open access. Thank you so much for patience.
Any questions? primary enucleation because there are many countries that do use neoadjuvant treatment prior to secondary enucleation, but aiming for enucleation. So I'm wondering how can you tell the intention of it and whether or not the eyes that had secondary enucleation have been at a higher stage initially. So whether it's really the enucleation or the higher stage of presentation that influences the outcome.
That's why the staging is made in a way where we have to categorize the eye at presentation, whether it's an advanced retinoblastoma or it is a salvageable eye. So only the features which show that there is a risk of advanced retinoblastoma should be considered for primary enucleation. The other eyes can be treated with chemotherapy and going to secondary enucleation if it kind of reoccurs. But does that answer the question?
Yeah, it does answer the question. So you're not saying that you always have to do primary enucleation, but it is fine to use neoadjuvant treatment and then a secondary enucleation.
Yeah, of course, because this is just for the advanced retinoblastoma that we consider primary enucleation as a better alternative than chemotherapy.
Thank you.
Thank you.
One last question.
I want to ask you that in RBCD, AJCC, do they classify or do they have a active seeding from the calcified or regressed seeding, and how you comment about the blood vessel within the seeds from retinocytoma having, whether they have such blood vessel within the seeds?
ISOO does categorize vitreous seeding, but retinocytoma is a completely different.
Active seeds and the non-active seeds, the calcified seeds.
Yeah, the RBCC does have a classification for active seeding and non, but the active seeds are the only ones which are classified into the advanced retinoblastoma. So that is where we need to consider primary enucleation, not the calcified one.
Thank you.
Thank you.
And the last speaker for this session is Abhilasha Maheshwari from India, Palladium 103 plaque brachytherapy for retinoblastoma, long-term follow-up.
Good afternoon, everyone. I'm going to talk about Palladium 103 plaque brachytherapy for retinoblastoma. This research was supported by the Eye Cancer Foundation. Radiation has been used in the treatment of retinoblastoma in the form of cobalt, iodine, iridium, and ruthenium, but there have been no prior reported cases of retinoblastoma treated with Palladium 103 plaque brachytherapy. We had an 8-year-old asymptomatic girl with a solitary peripheral superior temporal retinoblastoma in her right eye. The best corrected visual acuity in both her eyes was 20/20. On all the investigations, it was proven to be a retinoblastoma. So we placed a Palladium 103 plaque. As you can see, the position of the plaque is covering 2 to 3 millimeter around the margins of the tumor. And according to the 8th edition AJCC cancer staging system, this was a T1A M0M0 tumor, and 47.4 gray of radiation was received by the child over 5 consecutive days. A secondary vitreous hemorrhage was noted 46 months after the radiation and was successfully controlled by laser tumor demarcation. And with 19 years of follow-up, there has been no clinical scleropathy or local tumor recurrence. These are the pre-treatment and recent pictures of the child, and you can see the tumor is absolutely controlled with no recurrences. The tumor thickness over 19 years reduced from 2.8 millimeters to 0.9 millimeters. The take-home message is that the tumor control is attributed to covering the tumor margins properly, lack of vitreous seeding, and small AJCC tumor stage. The local plaque therapy can avoid exposure to potential complications from systemic chemotherapy treatments and delivers a more significant dose to the base of the tumor, thereby increasing the amount of radiation delivered within the retinoblastoma. Although this is just one case report, but we hope that this paves way for more exploration of palladium in these solitary small tumors in developing countries. Thank you so much.
Questions? If not, we are closing the session. Thank you for the talks.
program in the Toronto Hospital for Sick Kids for many years, and she has been managing retinoblastoma since 1988. She has done extensive work and research on tumor suppressor genes and developed new methodologies to accurately identify babies at risk of retinoblastoma prenatally. If Alfred Nasson is the father of genetics in retinoblastoma, then Brenda Gallie is the mother of genetics in retinoblastoma. In 2014, she was named member of the Order of Canada for her contributions to prevention and diagnosis and treatment of retinoblastoma, and in 2018 was recognized with the Helen Keller Prize of Vision Research. She has worked tirelessly and globally to improve the care of retinoblastoma children worldwide, including in Africa, especially Kenya. She was instrumental in guiding us even as we developed our Kenya retinoblastoma strategy, as well as our best practice guidelines. She's also been involved in retinoblastoma work in India and China. Brenda Gallie is married to Dr. Michael Jewett. She's a mother of 2 and a grandmother of 4, and she loves horses and the outdoors. Welcome, my dear friend.
That's my instructions. I always take Kahaki's orders.
So it's my pleasure to present you with this certificate of appreciation for sharing your valuable knowledge as a keynote speaker during the ISOO.
So I'm very honored to be a keynote speaker here today. I and all of you are part of this. I have to give my title, Africa, the lead in the changing the world for retinoblastoma. And you have all, in everything I've heard today, and all the initiatives moving forward, show that this is a very, very unique, special meeting today and special opportunity for the world. Indicated below are some of the charities that support all the work. I will touch on different pieces of. So Radi's challenge, Kahaki already introduced you to the little girl from Botswana who traveled through Abbey White to Toronto, where she also met Daisy Lloyd, who's the little girl just below there. And the outcome for each of them is different. In fact, today is the 21st of August, and this is the anniversary of Radi's death. She came to Toronto, but we could not save her life from a tumor that was spread into her brain. This is an image of the group at my first visit to Kenya, to Kisumu, where in 2006, where with families and different people, and out of that emerged all of this supported by Daisy's Eye Cancer Fund, because Daisy's family went on to really support Radi and all of the activities that went on through Daisy's. So by 2013, the Kenyan retinoblastoma strategy was well underway, and you can see some people you recognize in this room in the image in the upper right-hand corner, all working very hard. And the group in that room, and Helen Damaris and Kahaki will remember this very well, had a very, very heated discussion. All the players in retinoblastoma from Kenya arguing on whether exenteration had any role. And it was very important that everyone, including families, were present and part of this development of the guidelines, and exenteration was removed, as Kahaki referred to. So we have 2 guidelines in retinoblastoma published, and there might be others I'm not aware of. I'm I'm sorry. But the first was the 2009 Canadian guidelines, and it was very exciting when I went into Kahaki's office and Attendee's office, just here in Mombasa, just across the town, to find very coffee-stained copies of the published Canadian guidelines. So these guidelines were really in their office and being used. It was really exciting to see that in 2 places in Kenya. And out of that then emerges now the Kenyan guidelines. And I have a copy here. This is the real thing. And this is only my signature on it now, but I ask all the people who participated at this meeting to please sign my copy so it'll go down in history. And of course, since paper's going to disappear from the world, I'll have you all sign the real paper, and then I'll digitize it so I can keep it and the world can see who you are when we're all gone. Key to the success of the Kenyan guidelines was Michel Gichangi. He is the head of division, or was, I'm not sure what he's doing exactly now, Division of Ophthalmic Science Services in Kenya. And he really made this happen. He's here, somewhere in the room. There he is, waving his hand. He's a very gentle. Please meet him. He's a very polite, gentle, wonderful, smiling person, and he gives credit to all who participated, particularly patients and families who are key to these guidelines being really heartfelt and really meaningful. But once with Kahaki in the Kenyatta Hospital, we looked up the paper record of this patient, this family, and I took a picture of it because it was very thin and it was going to be gone soon. And I don't know what it looks like today, but that's more than 10 years ago, maybe. And it's maybe not possible to read it anymore. Unfortunately, the records, and we heard about people like Michel Angaro, who did not know that he had retinoblastoma. He knew nothing about it. No one has any medical records. And even in our modern developed world institution, we're still often on paper, particularly retinal drawings, which will disintegrate. So that's a problem for patients. So here we are, September 2011. This is the KNRDS in Mombasa, just like we might be here. It's not this location, but it's just down the beach a little bit, I think. And there we all are. Many of those people are here today. I can't identify all. I do identify Michel Angaro, who was wonderful and sang at our dinner party on the beach. And then he and I walked in the ocean with bare feet in the ocean, which he'd never done before. And I indicate Justin Liu. Justin is a developer who developed the database eCancer Care at the University Health Network in our health informatics research team. And that provided a registry, standards, quality of care, and shared care opportunity. However, families and people outside Sick Kids Hospital where it ran could never see it because it was only on a server inside Sick Kids. But Justin, just like everyone in this room, when they touch retinoblastoma, and families can't leave it. So Justin is still working on retinoblastoma databases, and he has built with a big team the new version of eCancer Care called Depict Health, because it depicts health being an optimistic view of the lifelong care for a patient who is afflicted by retinoblastoma. And you can see that the diagram indicates a right and a left eye, and all the symbols tell every treatment that that child has had. The lines across, of course, the whole patient, like genetic testing and systemic chemotherapy. Otherwise, they are eye-specific. This is a diagram built in Depict Health. You can see the drawings are quite good, and drawings are key to caring for retinoblastoma. But these are not on paper, but they use exactly the same template as the very standard retinal drawing for retinoblastoma used since the 1950s when the indirect telescope was invented. And you can see this particular patient also illustrates the AJCC staging, and we also put in the Murphy classification staging for the eyes. But I do encourage you to move to the AJCC because that will be a database that will let us really compare things into the future for outcomes at different stages and keep modifying that in regular revisions as we look at data. So this child went through all these treatments, and at the end, 4 years later, at this point where I have the little green box, he had recurrence in the all around the left eye. All the little yellow spots were tumor everywhere. This was his only eye, and it was about to be enucleated or need external beam radiation. That terrible choice that parents and caregivers have to provide at some point when the eye has good vision. So we haven't talked about that yet in this meeting. It's a very difficult time. So we didn't want to do either of those, and I met Lynn Murphy, who told me that the chemo plaque, which you've heard about from Aparna, my co-principal investigator on that clinical trial, and the chemo plaque was used in the first, this child was the first patient in the world to receive the chemo plaque by special access. The trial had not started. And all the tiny tumors disappeared. The calcified one did not disappear completely and kept recurring. And so we had a whole lot of other treatments, including what you'll see in the box, tylectomy, which is, we've heard two presentations on what I would call tylectomy. This is a term coined by John Chow, my colleague in China, who has done many, many of these and it's published. So this particular child, because partly of the chemo plaque and because of all the other treatments, is now 4 years out from that time when he could have lost his eye with 20/40, now has 20/40 vision. So Depict Health anchors the circle of care for each child around the family. The data is entered directly online into the database, which is the demos running on Azure Cloud, and Justin Liu is busy connecting the secure access database to the Depict Health database as we speak in Toronto to have that be fully functional very soon. The family can view the data, and they are the ones in control of who's allowed to see it. They can hire or fire their family doctor. They can invite their parents or any friend they choose to be able to see the record. And the patient, when they become 18 or even before, they can see it themselves. So Michel Angaro wouldn't be left in the position where he did not know anything about his retinoblastoma if this were running. So the a site is like a retinoblastoma treatment site. For example, there might be a primary site, for example, Sick Kids in Toronto, but the patients come from Alberta, and they may also have a second site, which would be Alberta Children's Hospital or other institutions. The parents must sign consent, communications consent, in order for the child's data to be entered into the database. The institution, the site, remains the custodian of the data, and Cancer Care is a tool for understanding and communication, including with family and anyone, and keeping the record intact. But the drawings in Depict Health are much better than the ones on paper. With an additional second consent that's optional for research, then that data would become coded and aggregate, and that would be given back automatically to the site, so that the site that treated the patient wouldn't lose the opportunity to publish and study their own data in this way. And that's actually been fantastic for us at Sick Kids, because eCancer Care holds all our data, so we can always go back and retrospectively look at any questions over the past years since we started that in 2003 at Sick Kids. The coded data will also, with consent, go through to the Global Reach, which is a new pediatric cancer data commons built out of Chicago. Many of you in this room are part of building Global Reach as a new data commons. Previously, all the other sites you see there with very nice, unique names were where ethics board approved clinical trial data would be loaded into the data commons. So after the clinical trial, then any other people wishing to restudy that data or check if it was accurate could actually access the data with the whole approval, ethics board approval, everything attached to that. So when when they considered building retinoblastoma, which had never been there, we were really excited because they asked us, if we would help with the Depict Health database, because we had a full database encompassing all the details you need in retinoblastoma, and that's been provided a skeleton for what they built into the data commons for global reach. So the aggregated coded data goes out to global reach, and that saved us having in managing Depict Health with the International Consortium that licenses Depict Health from the University Health Network where I built it, global reach database skeleton is built on Depict Health as the draft, and then many, many changes and discussions are going on as we speak. That data then moves on to the ethics board approval, and for other people, any of you could ask for this data with your institutional approvals, and it would be released data. The difference, I'm just going to back up here, between the other data commons, which take already clinical trial data, so it's already manipulated data that goes into the commons, but global reach through Depict Health will take primary data from the bedside or clinic. So we have huge opportunities right now that we've heard about today, and in many directions for changing outcomes from retinoblastoma. This is the same patient I showed you previously, and you can see it's the same timeline. I just squished it down by entering 2036 as the final date showing here. So we're now looking really at the full future life of this child and how it could be imaged. And I put S everywhere. This patient in the future will be having surveillance for second malignant neoplasms, which you've heard of patients dying of their second malignant neoplasms today. And the work that Jessie Berry and her team in CHLA is spectacular. And I think that the time will come, not far off, when future regular blood tests will look for evidence of cancer anywhere in the retinoblastoma survivor, and identify that there's a cancer somewhere by the cell-free DNA methylation pattern or other things. And that studying that DNA in detail may tell all the caregivers what cancer to start looking for, because the signature of different cancers will be evident in that DNA sample. So I think this is a very, very exciting time. So rollout of Depict Health will be this year, with implementation fully running in Sick Kids, Alberta Health, and other sites within Canada. And we need all the legal framework, all of that stuff done that I hate. It's all being done, but it will be good. And we did have a whole timeline of all the other different parts of the world where we'd like the order we thought Depict Health might roll into. But I've now modified that totally because of this meeting. So we put right after year one in Canada, we put ISOO Africa, bringing us to Africa. And I think that this is a great, great opportunity. So I think we can look forward with great optimism for the future. And it's why I put in my title that Africa can really lead the world. What happens here, with all of the support of all of the caregivers, people devoted to retinoblastoma, and patients, and being tightly involved at all times, that will change everything for us. Thank you.